Assalamu alaikum viewers. I hope you are fine. Here we are going to see another video of the radical nephrectomy of the left side. Same is the case here. This is another 65 years old non-hypertensive and normoglycemic lady who is having around 6.5-7 centimeter mass in the lower pole. We have already dissected the colon, mobilized the colon, identified the ureter, and mobilized the lower pole as well. So we were moving swiftly towards the hilum, but here we found that there was another vein going towards the kidney. So we decided to mobilize and cut the gonadal vein so that we can have an easy access on the aorta and the pedicle. We encountered a small bleeding vessel in the periaortic lymphatic tissue, or it may be one side of the gonadal vein. So that has been clipped and the area has been cleaned. Now we are moving towards the dissection of the pedicle. Here you can see that there is a small vein which may be having a confluence medial to the aorta, or it may be a separate vein going towards the vena cava anterior to the aorta, but we have to dissect it. So we decided to dissect this, whether this is a tributary, a separate tributary, or a tributary which is going into the main confluence of the vein. But we have decided to clip it separately and then cut it separately so that we can deal with the rest of the pedicle. So we found a pulsation here. Is a big artery just posterior to it. However, as we have seen two veins here, I'm expecting another artery as well. So clip the artery first so that the vein becomes decompressed, then clip the vein, then cut the vein between the clips, then clip the artery again, and then clip and cut the main vein, and then do the artery. So one vein has been cut. Now we are proceeding towards the main renal vein. However, it is important to know whether there is another artery or not, or there is branch of the other artery or not. What I felt was that there is a big artery which has divided into two. Since we are working close to the kidney, that's why we have ligated one branch, but the other branch will be there. So we are looking for that branch, the second one. As you can see, the vein is already quite full with blood. If it was the main artery, it should have collapsed. So we are looking for another artery here. The vein did not collapse. So we dissect posterior to it, but this time we are lucky because the origin of the artery from the aorta this time is the usual origin, which means that it is posterior inferior to the vein, so it is easy for us to dissect it, clip it, and then complete the procedure. So we have found another branch as well. This is the periaortic lymphatic tissue. It always accompanies the arteries. When I'm unable to find the artery, I always try to look for the lymphatic tissue. So whenever there is a lymphatic tissue, it means that this lymphatic tissue is harboring an artery. So here we see another artery here, but as I said earlier, This is bifurcation, so the main stump remains lower down. However, since we have to cut the vein first, because it is anterior to the artery, we clipped the branch as well, and then we saw that the vein has collapsed. The pressure within the vein has reduced, and we are now easily able to dissect it. So the posterior surface of the vein remains, for which the right angle is the best gadget. However, in the process, I think we injured a small vein in the Ureter, or maybe a small tributary of the renal vein, but it is not a major bleed. The patient is quite stable. We can see all the structures, so let's proceed with the clipping of the vein and then cutting it, rather than panicking. So now it is cut in half, and then slowly, gradually completing the cutting of the vein. You can see the surface of the aorta behind. Little bit of cleaning is required because some small vessel bled at the time of application of the right angle. There is no significant bleeder. The plane, the field is quite clean now. So we dissect proximal to those two arteries that we clipped, and we found that our supposition was correct. There is a single renal artery arising from the aorta, and which is then bifurcating into two branches. So we clipped the two branches separately. Now we have decided, as the vein is out of our sight, we can easily dissect the para-aortic lymphatic tissue and dissect out the main stump, which can then easily be clipped. It is important to dissect the tissue posterior to the artery. Here again, that principle remains the same, that dissecting the lymphatic tissue away from the artery will give you more length of the artery. It is a length which is sufficient enough. Instead of 2 clips, we applied 3 clips, and still we have space, so we can cut both the branches of the artery separately. So the artery is almost complete now. Same goes for the adrenal gland, the upper pole and the adrenal gland. Horizontal dissection. The rest of the procedure is the same as described in other videos. Thank you very much for watching.